So these are survival curves for a patient with metastatic disease treated with primary chemotherapy. You could substitute really any cisplatin-based regimen into this particular equation, whether that be dose-dense MVAC, standard MVAC, and rarely do you see 5-year survivals. It's only about 10% of all patients. This next slide is a Prozac-worthy slide. If you look at the salvage for patients with metastatic bladder cancer who failed primary chemotherapy, we have few agents that really have efficacy. Perhaps pemetrexed with about a 9-month overall survival, docetaxel with about a 9-month overall survival. None of these will cure patients. They at best will temporize things. So what about other treatment options? Where are we moving? Well, immune therapy is important, and we're seeing now that immune therapy is coming into vogue for the management of bladder cancer. And we know that in other tumors like melanoma and lung cancer, where there's a high mutational rate, we see responses to checkpoint inhibitors. So what are checkpoint inhibitors? Well, these are agents that will regulate the immune system. And there's actually a pathway that we see that goes on with immune regulation. Cancer cells will release antigens into the lymph nodes, into the circulation. This is due to immunological cell death. They are presented, and a variety of different agents will regulate that presentation to the lymphocytes. These include tumor necrosis factor, interleukin-1, interferon alpha. Agents that will negatively affect that interaction include IL-10, IL-4, and IL-13. The immune cells are primed and activated, and agents that will inhibit that activation include CTLA-4, PD-1 and PD-L1, and the prostaglandins. Eventually, these are trafficked to the tumor cells and then cause cell death by infiltrating the T cells. Perforins will then cause the cells to lyse and to die. These are also negatively regulated by VEGF, and then the cancer cells are recognized by the T cells, and you have immune surveillance, and you can remove cancer cells from both lymph nodes, any metastatic site in the circulation. Well, what about PD-L1 and PD-1 expression in bladder cancer? This is from our phase 1 experience looking at PD-L1 and Atezolizumab, which is a PD-L1 inhibitor. We found that using this SP142 assay, that in bladder cancer, about a third of patients had high levels of expression of PD-L1, a third of patients had intermediate levels, and a third of patients had no expression. Now, surprisingly, this was not in the tumor cells, but this was in the immune cells that were present with bladder cancer. Other studies have shown that there is tumor cell expression of PD-L1, and I think this is assay dependent as well as when we actually look at these particular specimens in the course of their treatment overall. So our first study started in 2013, and interestingly, our best patient on this trial just relapsed, so that's 4 years ago. And he was a gentleman who had failed 3 chemotherapeutic regimens and developed metastatic disease in his lymph nodes. He was a complete response, and unfortunately, he just relapsed. And he's going to go on to one of the secondary trials we'll talk about a little bit later. But in our first 92 patients, and this was published in Nature by Tom Powles, predominantly bladder primaries, we see that a median age of 66, 79% of patients having disease in the bladder, an advanced group of patients with 79% having visceral disease, 37% having metastases to the liver, 94% having received prior platinum-based chemotherapy, and poor prognostic factors, including less than 3 months from the last prior chemotherapy and hemoglobins of less than 10 in 42% and 17% of patients, respectively. So giving atezolizumab intravenously every 3 weeks, we see that about half of patients who have high levels of expression of PD-L1 in the immune cells responded. And in fact, we saw complete responses in 20% of those patients. Now, this is where this staining breaks down, and we should not be using PD-L1 staining to select patients for these for standard treatments, because 17% of those patients who were weakly positive or negative for PD-L1 had a response to treatment. We saw responses in patients who had visceral disease, 38% overall of the patients, and also in patients, as we said before, who had low levels of PD-L1 expression. Now, this is the presentation I gave at ASCO about 2 years ago. We're going to update that at ASCO GU this year. But the median duration of response had not yet been reached. And interestingly, the duration of response is independent of PD-L1 status. So if you respond, you've got a good chance of continuing your response for a fairly long period of time. I'm going to be updating the survival data at this year's ASCO meeting, GU meeting, but as we see, for those patients who have high levels of expression of PD-L1, the median overall survival has not yet been reached. 39% 6-month survival for the progression-free survival, and 10% for the 0-1s. For those patients who did not express PD-L1, it was an 8-month survival. So this led us to go on to a larger trial, which Jonathan Rosenberg led. This was the IMvigor210 trial, and this had actually 2 sections to it. One for those patients who were platinum experienced. The other group of patients were those patients who were platinum ineligible. And I think that this is going to be very, very important for the elderly patient that we talked about earlier in the session. So overall, the platinum experienced patients, 310 patients, 119 patients in the platinum ineligible patients. For those 310 patients, they're a very, very similar group to what we had in the phase 1 trial. This data, of course, is less mature, but if we start looking at PD-L1 status in the immune cells, again, we see that same loose pattern for the high levels of expression, 28% response by RECIST, a 15% complete response rate, 9% and 2% for those who do not express PD-L1. So again, we see this pattern. Now, what I think is very, very interesting, and we, as oncologists and urologists, we have to keep this in mind, is that the response criteria are different than what we have with standard chemotherapy. Why? Well, in our trial, because these immune cells may infiltrate the tumor cells or the lymph nodes or the liver, we treated patients if they were asymptomatic past progression. So 19% of patients who were entered in this study were eligible to be treated past progression. And we saw that we had responses in these patients. We re-scanned them a month after we continued them past their initial progression. So we have to be very, very careful that we're not seeing something called pseudoprogression with these patients, that they actually are truly progressing overall. Survival data, again, this is not as mature. For the 2-3s, 12 months. For all patients, 8 months. And for the 12-month survival, it's 37%. We don't see any difference in patterns if they're for the all patients versus the second line only. Now, if we start looking at different types of bladder cancer histology, we have the luminal type, which can be considered to be the type 2s of the inflamed, the basal type, which are immune suppressed, and then the papillary type, which are the immune desert. It seems that the responses tend to occur in those patients who have the luminal type 2 types in their histology. And also, if we start plotting out mutational loads in each individual patient, we'll see that those patients who have higher loads of mutation will actually do better and have a higher response rate. And again, that separates, again, the luminal type 2s. So this is a potential for neoantigen generation and recognition by the immune system. Now, what about frontline therapy? Well, of course, if we move these treatments up early, we would expect a better response rate. And on the left-hand portion of the slide, I have the de facto standard of care, which is gemcitabine and carboplatin. In the EORTC, they looked at this particular combination. They compared it to a methotrexate carboplatin vinblastine combination. They found that this had a very, very similar survival, but objective response rates of 36%, median overall survival of 9.3 months, and a 1-year overall survival of 37%. No patients living 5 years. In the cohort from this study with atezolizumab treated for platinum ineligible patients, these had not received prior chemotherapy, a 24% objective response rate, a median survival of 15 months, 1-year survival of 57%, and not mature enough to see a 5-year survival. So this is comparable to what you see with carboplatin and gemcitabine. And I would also argue it's comparable to what you see with cisplatin-based chemotherapy. Of course, we need randomized trials to prove that. So what are some of the other checkpoint inhibitors that are being evaluated? Durvalumab is a PD-L1 agent. It's administered every other week. These patients receive this for a year. There was a urothelial bladder cohort from a phase 1 study. Their assays looked at both the tumor cells and the immune cells, and using their particular antibody, they found that if you had no expression in the tumor cells or the immune cells, and these are small numbers, none of the 14 patients responded, but there was a higher response rate of 46% if you had positivity. Very, very similar side effects. The side effects we see of those are inflammation, diarrhea, liver function abnormalities, as well as rash. Nivolumab, this is approved for renal cell carcinoma as well as for lung cancer. This was evaluated in a single-arm trial and presented by Pam Sharma at ASCO last year. And again, we see a 25% response rate, complete response rate of 6.4%. No correlation with PD-L1 expression, progression-free survival of 2.78 months, and a median survival of 9.72 months. So the other thing I think which is very, very interesting here is we don't really see this really particularly great progression-free survival. Think back to Provenge a couple of years ago. In progression, you don't see it there either, but you do see a survival, but at least a trend towards a better survival. Pembrolizumab is a PD-1 antibody, is dual blockade of PD-L1 and PD-L2. It is, again, approved for lung cancer. I believe it's also recently approved for head and neck cancer. Betsy Pilmak just recently published this data in Lancet Oncology, where she gave pembrolizumab to patients who had prior platinum-based therapy. As you can see, again, these are very similar to our patients that I presented before, and a very similar response rate of 27%. If we look at the progression-free survival, it's not, again, not great. It's 2 months, but the overall survival is about 13 months. So what about randomized trials? Well, this is the first randomized trial to be presented looking at a checkpoint inhibitor in metastatic urothelial cancer. Joaquin Belmont was the PI on this study, and this took patients who had had at least 1 to 2 lines of platinum-based chemotherapy or recurrence within 12 months after neoadjuvant or adjuvant chemotherapy, randomized to pembrolizumab every 3 weeks, or dealer's choice chemotherapy. In Europe, they use vinflunine, which is the standard of care, which is probably not better than any of the other chemotherapeutic agents. 542 patients were randomized to both arms. There are still 49 ongoing patients in the Pembro trial and 3 in the chemotherapy arm. And this is showing a survival benefit. The median, the hazard ratio is 0.73, a median of 10.3 months versus 7.3 months for the chemotherapy. Now, what about, again, moving pembrolizumab up front in these patients for those patients who are platinum ineligible? This was presented at ESMO this year, 100 patients overall, predominantly bladder cancer, 87% of patients having visceral disease. And we again see that same 24% response rate with 6% of patients having a complete response. So very, very similar activity across the board for all of these agents. If we start looking at subgroups, there may be a better activity in the lower tract disease, but visceral disease, as we've seen consistently with the other trials, does also tend to have a lower response rate. Now, there are a variety of different studies that are moving up front at this particular point. I'll disclose that I'm on the steering committee for this trial. This is the DANUBE study, which is taking MEDI4726, which is an anti-PD-L1 inhibitor, combining that with tremelimumab. It's like giving ipi-nivo, a very similar combination, comparing this to PD-L1 monotherapy compared to standard chemotherapy in metastatic patients. And this trial has closed in the United States, is still actively accruing in Europe as frontline. And then the Javelin trial is another trial which is actually fairly interesting from the standpoint that it's a maintenance trial where patients are receiving upfront chemotherapy for 4 to 6 cycles and then being randomized to checkpoint inhibition therapy or observation if they have a partial or complete response initially. There are also trials that are being performed with atezolizumab as well as pembrolizumab upfront in bladder cancer. So in conclusion, checkpoint inhibition therapy demonstrates significant anti-tumor activity in cisplatin-treated metastatic urothelial carcinoma. Atezolizumab is FDA approved. I would expect that pembo is going to be approved at some point this year, but I'm not sure when. Also, atezolizumab has filed for, or Genentech has filed for, frontline use in patients who have are platinum ineligible. And I think what we really need to understand is a more standardized way of looking at these markers, because they really do not tell us anything at this particular point and should not be used to determine whether a patient goes on this treatment.